Hey there, and welcome to the Hit Like a Girl podcast. My name is Joy Rios. I'm the show's host, and we have the opportunity to speak with experts about the 30,000 piece puzzle that is healthcare and health IT. And every one of our guests gets to share their piece of the puzzle. So excited to share our guest today, Nichole Sweeney. Would you mind taking a moment to introduce yourself?
Sure. Thanks so much for the opportunity to be here today. My name is Nichole Sweeney. I am the General Counsel for CRISP Shared Services and also the Chief Privacy Officer. CRISP Shared Services supports 6 HIEs, Health Information Exchanges, and health data utilities throughout the country. And I also directly support 2 of those health data utilities in Maryland and DC, also as their General Counsel. And chief privacy officers. And I'm just generally kind of a data interoperability privacy nerd and really enjoy these conversations.
Okay, so let's just spend this time nerding out, but I want
Love
to
it.
start with the basics. Like for somebody who doesn't know what an HIE is or that whole transition, there's a lot of acronyms.
Yeah.
We've got HIE, we've got TEFCA, we've got now QHINs, and then, under the umbrella of interoperability. For somebody who's kind of just getting on board to this conversation, can you help them catch up?
Sure. How many hours do you have? No. Yeah, I will try to give a very high level overview. So I think the easiest way to explain health information exchanges and their evolution, which is health data utilities, is to really think about what normally happens and how data exchange happens in just normal practice for clinicians, right? So you go into your clinician's office and he or she or they maybe, takes your blood pressure and then you see a specialist, right? And the specialist sees your blood pressure and is like, oh, that's a little high. I wonder if it's normally that high. In the old days, they would have called up your clinician or faxed something over and asked for your records, and it could have taken days or weeks or sometimes even longer. Sometimes they never got there. And so what health information exchanges do is they allow that real-time access to people that are allowed to see the data for purposes for which they're allowed to see it. So the same clinicians who would be seeing the data via paper or fax in a very long time can now see it at the point of care when they're there. So it's integrating different systems and different data streams and normalizing them and translating them. So no matter where I show up, even if I show up halfway across the country or entirely across the country, that clinician, as long as they have the legal authority to see my data, can see it in almost real time, if not in exactly real time. And the same thing goes for if clinicians need to send things for payment to your payers so that you can get prior authorization faster, and for other reasons as well. It really just enables things that should be happening anyway much faster. And then taking that one step further, this concept of health data utility, which Maryland has really embraced in CRISP Shared Services. The idea here is that health is whole person. We know that, right? It's not just me showing up at my clinician. It's where I live. It's the environment that I'm in. It's my social structures. So if we're just exchanging data about that one little piece, we're missing so much of health, of healthcare. Not to mention the human service aspect of it, which people may be eligible for. And if they are, we want to make sure that we're telling them that and getting the data to where it needs to be. So the health data utility takes that HIE concept and plugs into it the public health data, right? So data that might be coming in from other sources and sharing it as appropriate too. So an example of that is COVID immunization data, right? We had all these people going to these huge stadiums. I was one of those people. And to get that information back to my clinician, it would have been very difficult for the Maryland Department of Health if they didn't have someone like CRISP who was already connected to all the hospitals that could then take that data and tell my clinician, hey, Nichole has had her vaccine, you don't need to call her. Or, oh my goodness, Nichole hasn't had her vaccine and she has all of these co-occurring conditions. So please call her. And now is usually around the time as a chief privacy officer that I like to mention that patients are allowed to opt out. So if you hear all of this and think, ooh, I don't want my data to be shared in that way, first, please call me because I can tell you all the reasons I think it should be shared and why the good is better than the pros are more than the cons. But if patients ultimately, it's their choice. If they don't want their data exchanged through a health information exchange, they can go and opt out of these health information exchanges.
So really helping build a little bit more of a comprehensive picture of data. And when you're talking about working with 6 HIEs in different regions, I mean, some people visit Maryland and vacation in Oregon and maybe have a health event that happens there. So we want that exchange of information to be available.
Exactly. I give the example all the time of when my son was 2, we were at Disney World and he got an ear infection. And it was great to be able to show up at an urgent care in Kissimmee, Florida, right, and have my son's records available. He's allergic to penicillin, so it's great to be able to have that right there, even though we're thousands of miles away. Yep, exactly.
Okay, so tell me now, from what I understand, well, I'm going to see you in person at the Civitas conference soon. So I'm excited for that. And can we talk about what happens there? This is it'll be my first time going to this particular conference. And I just feel like it's going to be a lot of policy and really understanding, okay, what's going to happen with our healthcare data, maybe in the next year and beyond. Do I have an accurate reading on that?
Yeah, I think that's pretty accurate. And I think there are different levels. So the Civitas conference brings together HIEs from all across the country and also what's called regional health information collaboratives. Regional health improvement collaboratives. And they are very similar to HIEs in some ways and not in other ways, but we all have the common goal of interoperability for better health. And we also very much believe that the solution is at the local level, and that we should be taking solutions at the local level and seeing how we can employ them across the country rather than doing the same thing in different areas that might not work. How can we learn from each other and say, oh, this works really well in Arizona. How could I take it and bring it to Maryland and make it work for my state? So that is a lot of what the conference is about. It's about wins in different places, and talking together about, how can you take this win and make it a win for you? Or how can you take that win and realize that would never work, right? So let's get that off the list. So it's a lot of sharing. This particular conference is based on relationship building and the various interested parties that we have, and understanding how that all connects into the public-private partnerships. So there's going to be speakers in that area as well. And then I'm really excited. We did this last year and we're doing it again for something we're calling the unconference. And that is basically, you get to go to the conference, but there are these little sessions where it's much more interactive. It's more just people sitting around tables and brainstorming about things like common issues that we all have in healthcare exchange, in interoperability, that we're trying to figure out. So the lectures and talks are more about like, what have we solved? And the unconferences are more like, what is still out there and how do we do this together? We do that all year round with Civitas, but this gives us a platform to come together and do it in real time. And I'll actually be facilitating one of those. I'm very excited. One of my areas of expertise is sensitive health information and data exchange, specifically, around reproductive rights. So talking through how do HIEs and really anyone honor what patients want if they consider their data sensitive, and they do not want it to be shared, but want all of their other data elements shared. So that's something we're
Okay.
talking about from a legal and policy perspective.
I can't wait to talk to you more about that. So we've been doing this federal draft rule book club in our Hit Like a Girl pod community. We've been reading it's awesome. And so one of the ones that we covered was the HIPAA privacy rule with reproductive rights.
Mm-hmm.
But that's still just a draft, right? It hasn't passed. Can you share with our listeners what that is about and why it matters?
Sure. So the HIPAA draft rule, and again, this is a draft rule. So for those of you who don't eat, sleep, and breathe regulations like I do, a quick primer on the federal regulatory process. And this is something that I was involved in for over a decade, working with SAMHSA and CMS and ONC, helping them draft these regulations. So I get to see all this stuff in real time, which helps demystify it in a lot of ways. You can follow the system if you sort of know the steps. If you don't, it seems totally intractable, but I'll hopefully explain it in a way that makes sense. So just from a rulemaking perspective in general, right, we have laws that Congress has passed. In this case, it's HIPAA, right, which was passed in 1996 and updated 3 times since then, I think, something like that, quite a few times. But in the meantime, and in the law itself, there's lots of things that say like the secretary shall, or, it's sort of, the law is kind of the bones, and not even like all, what do we have, 212, whatever, not even all 212 bones, like 14 of them. And then you're like, how do I make this into a person? And that's what the regulations do. So after a law is passed, there are specific places in the law that say like, hey, you federal agency, fill this in here. Or we're going to give you discretion to change this in the future based on changing law or changing things that might be going on out there, like in the case of Dobbs, and various things like that. So once the law is passed and the president signs it, the relevant agency, in this case it would be Health and Human Services, figures out how to actually implement this thing, how to take the thing from 14 bones to not only 212 bones. I can't wait for someone to comment on this and tell me the actual number of bones, by the way. I'm looking forward to that. But we're going to pretend it's 212 if it's not that. And like the flesh and the hair color and the eyebrows and the eye color and all that sort of stuff. I'm going to take this analogy way too far in a second, so stick with me. But in any event, they really figure out, what does this actually look like and how are we going to implement it? And so when you are a corporation or anything else like that out there that has to comply with a law, it's not just the law that's on the books that Congress writes. It's also the regulations where they flesh all of this out and figure out, okay, what are we going to do? So since 1996, HHS has been issuing regulations, and if you have heard of the privacy and security rule, or the privacy or security rule, those are the HIPAA regulations 45 CFR 164 and 160, which is scary. Someone's going to correct me on that too.
Impressive. Wow.
It's probably not right. Someone's going to correct me on it. But those are the regulations that correspond to the law. And they really say, okay, this is what the law said, but we're going to fill this out here. This is a little bit more here, a little bit more there. And because they have the force of law, there needs to be some sort of public input. So the public input in the legislative process, right, is that if you don't like what your legislator did, you get to elect somebody else next time. The people in the agencies many of them are there for their entire lives. And frankly, we want them to be, because they need the type of knowledge that they have accumulated over a lifetime to do what we need them to do for us. But if you don't like what they're doing, you can't, unelect the head of whatever agency or the, middle person at the agency that's writing a lot of the regulations and doing a lot of the groundwork for that. So, and you wouldn't want to unelect them because they do an incredible amount of work. They work their butts off. to make these things real for us, and they really grateful for those folks. So to hold them accountable and make sure that there's public input, when they draft these regulations, they will put out proposed regulations, right? So they will say, this is what we plan on doing. And then they will publish that in what's called the Federal Register. If you ever want to go on and see that, you can go to regulations.gov and see all of the regulations that are out there, including things like how many balloons should be let out in the air at any time. There's like lots of fun things if you get really nerdy about it. Once it's published, people have typically around 60 days, sometimes less, sometimes more, but typically around 60 days to comment and say, hey, this is where I'm going to take the analogy too far. Like, really like what you did with the hair, but maybe you should put highlights in it instead. Or like, hey, you're missing a finger on that hand, right? Like if you really want this to work, you really need like an opposable thumb. So people get to write in and say those types of things. Like these are the consequences of your proposed rule at a discrete level, right? So there might be many proposals. And then thousands, sometimes tens of thousands of people and companies write in. And then based on what they say, the agency has to go and read all of those comments. So every comment that comes in, they have to read them, and then they will put out a final rule. And the final rule has to include all of the comments that people wrote, not word for word, right? It doesn't say Nichole said this and Joy said this, but it says people generally have this concern. And then they have to respond to it and either say, like, thank you for the concern, but we think we don't agree with it for these reasons, or, you know, thank you for the concern, and we're so glad you brought it up because now we're going to change X, Y, and Z. So ultimately, a final rule is published, which typically takes effect 60 days after it's published, and it includes everything that the public says, which is really cool. It's a really awesome thing to be able to be a part of the process. Sometimes you can actually sort of see yourself in it. You can see like a little phrase that you put in there or something. It's very gratifying. And so we end up with a final regulation that, again, really fills out the law, and companies are have to abide by that as well. And it's based on the input of what folks say. I think what's important to know is it's not like a scale or a balance. Like they don't put all of the people liked it on one hand and people that didn't like it on the other. And if one weighs more, they go with that. They could have 90% of comments that say, we don't really think this is a good idea. And they could still decide. In fact, they could have 100% of comments that say they don't think it's a good idea. And as long as they explain that they read the comments and listened to them, and these are the reasons that they disagree with that, they could have the exact same proposal. So that was probably much more than you wanted to know about administrative procedures.
No, I mean, and there's a couple ways that I want to weave with this. And one is as somebody who has read several draft rules and final rules, and then, you know, made business decisions based on those, like ultimately those are the rules of the road that says, here is how we will be proceeding. And I find that these draft rules are oftentimes hundreds of pages long. They're often written in a way that's not particularly easy on, you know, for the reader. And then I think it's also quite intimidating to submit a comment because either as an individual or if you're collectively gathering comments to submit, perhaps like on behalf of an association or something, to submit it with very formally. And like, that's the part that I want to help demystify for people, because I have never submitted a comment. I've definitely had thoughts about it, and, you know, I've things that I've read, but I haven't gotten over the hump of like, you know what, you need to be thinking about X, Y, and Z. And I don't know why that is. But it sounds like you have probably a lot of experience either collecting or commenting on these rules. And I kind of want to pull the curtains back of what is that experience like?
Sure. So I have lots of experience on both sides of it, right? For 10 years, I read them and helped CMS and HHS draft final regulations based on what they said and what the agencies wanted to do. And now I'm on the other side where I'm drafting them for our trade associations. I'm going to start with a person who reads them, sort of to demystify that or make people feel better about commenting on these things. There are lots of comments from lots of people that range in levels of understanding of the different areas, right? So there are going to be some big name law firms that will submit a comment letter that might be hundreds of pages long. Like sometimes I was reading them and I was like, is this longer than the regulation? Like, how did you make a comment letter that was longer than the regulation? This is absurd. And then there are other ones that are 2 paragraphs long, right? And they might be about one issue, or they might be about a theme. A lot of them are very personalized. And both have an incredible amount of value. And I will say, as someone that has read them and has been in the room when the government is drafting these regulations based on the comments, those ones that are 2 paragraphs long, like they're not just like, oh, this is 2 paragraphs, this person didn't know what they're talking about, we're just looking at the legal ones. They read those and they make a huge impact. And I'm thinking of one example in particular when I was working with SAMHSA on some of the Part 2 regulations that are related to substance use disorder. And folks were tearing up. I mean, it makes an impact. Individuals make an impact. I think especially people who are able to say, this personally will impact me in this way, or I have had this issue. And the same thing for corporations, right? If you generally kind of write about all of the like political reasons or strategic reasons you don't like something, it's definitely going to be read. But I think the ones that really make more of an impact are the ones that say, yeah, we kind of agree where you're going. Like what you're trying to do is a good thing. Let us tell you with our hands dirty, boots on the ground, like why this probably isn't going to work, or it might work, but here are the unintended consequences. So anyway, if you want to submit a comment, you should. They are all kinds up there from all different types of folks. It's very easy to do. You can submit it online. So you would go to regulations.gov and you can look up the rule by what's called a RIN number, which would be on top of the regulation. Sometimes I find it hard to find those, are like 10 digits long. So you can search by agency, you can search by keyword, and then it's like writing an email. You can, or if you write you write it out in a Word document or something, or a PDF, you can attach the PDF. So submitting the comment, not actually writing it, but submitting the comments, even the ones that I write that are 10 to 15 pages long, typically takes me less than 5 minutes. In fact, I would say most of the time it takes me less than 2 minutes. It's a very, very friendly website for users. They've done a really good job with it. So really highly encourage folks to submit comments. And then when you're submitting a comment, if you see the rule, and this happens to me too, and this is what I'm paid to read the rules. And when I see thousands of page rules, I'm like, oh my dear God, like, where do I even start, right? Like I get overwhelmed. I have to like take a walk around the block.
Can I chime in with that? Because that's what we've been using AI. We've been using Chat PDF, and basically all of the draft rules come in a PDF format that I can then plug in and essentially ask questions of it. And I say, what are the top 10 takeaways? And it'll point me to the page numbers. And for like $5 a month subscription for being able to do this, it has been a total game changer. We're calling it the Oracle. And in our book club, we're just like, okay, there's 5 or 6 of us together, sitting around looking at the same document, but with different perspectives. I was like, okay, what comes up for you, Susan? Like, what are you thinking about? And what about you, Sarah? And so we'll ask questions and it'll point us to the page within the document. And that has been the part that has been really empowering over, just being able to use technology to help get farther faster, because it is a slog. Before, there's been people who like print these out and get their highlighters, and you've got the little like Post-it tabs
Yeah,
of like, themes. And you're like, that's a heavy lift to do that.
it is. Literally and
If,
figuratively. I've like carried
yeah,
them around in backpacks before. So I love that. I had not heard about that before, and I am going to share the good news of that with other
please
folks.
do. Please do.
Yeah, that is excellent. And I would say if you don't want to use AI, or like you don't want to pay the $5 a month, or if that seems, scary for one reason or another, a trick that I use, and like I use this even now as somebody who again is paid to write and comment on this rules. I have lots of other stuff to do too, right? Like don't want to just read
Yeah.
these rules
Yeah.
all day. There are typically FAQs that the agencies send out, or fact sheets, and you can really go like point by point within the fact sheets and see the non-legal language of like what are they trying to do with this, and you can comment on that. Like you can get down into the granular, as a lawyer, like should this be and or whatever.
Mm.
There are people that are going to do that, but if you are concerned about the concepts, which I think a lot of individuals are out there, especially with the HIPAA rule that we started talking about, and then I got lost somewhere, which is what I usually do. You could comment on it just knowing the concepts. And the same thing too is true of the rule itself. So if the rules have executive summaries, and like the
Mhm.
first 5 or 10 pages, if you could just read the executive summary most of the time and then decide, oh, I want to dive in more there, or I don't want to dive in more there, I know enough about it now. So those are some like kind of quick tricks. I love the AI thing.
I
But if
have
you
one
don't,
more. I
please,
want to
yes,
run it by you because this was
yes.
before AI. And for the last several years, not so much with the draft rules, but with the final rules,
Mm-hmm.
instead of, they're basically the same page length, which again can be thousands of pages. And then you're reading comment, response,
Mm-hmm. Yeah.
and it's pages and pages. So I would do a find for all of the tables and then
Mm-hmm.
just pull out all of the tables, because that is typically where they have collected what has been finalized essentially in list format or
Mm-hmm.
table format. And then I
Mm-hmm.
would just be like, here's the tables. And then now all of a sudden my 1,000-page document is down to 100 pages. And that has
Yeah.
been super helpful too.
I love that idea, especially because, it might not give you the details, but it gives you enough to know where you want to go to the details, right? So
Yeah.
it's like a cliff notes for starting. You could do the same thing potentially with just like finding we propose to finalize, or we are
Mm-hmm.
finalizing. And then you
Mm-hmm.
could just see like the 2 sentences of what they want to finalize. I mean, they're going to have pages and sometimes 20, 30 pages of the reason
Exactly.
that they're going for this. But if you just if you just do the tables, or if they don't have the tables, find, search for, we propose to finalize, or we are finalizing. It's usually going to be at the top before they talk about, they're going to say it and say it again, and you can just pull those out. So yeah, that's another great trick.
Okay. I know we can talk all day and geek out, and I want to take up a little bit more of your time, but
Sure.
I do actually want to circle back to the HIPAA privacy rule around reproductive rights. Like, okay, so it hasn't been finalized, but let's talk about what it is and why it matters,
Mm-hmm.
and what it would entail. I guess from a patient perspective, what information could be exchanged to kind of
Sure.
get a little cohesive.
Yeah. So, um, uh, for context, right, a little over a year ago, the Supreme Court passed what we call the Dobbs decision, right? And that, basically, in a nutshell, said to each one of the states, it's up to you whether abortion is legal and when it's illegal. It's up to you, state. You get to decide. And when that happened, many states immediately made it illegal. Many states made it illegal after a certain number of weeks. Most states actually make it illegal after a certain number of weeks. So, with specifically the illegality in some states for patients and also for providers if they perform some of these procedures, and with health exchange, right, taking us back to the very beginning of the conversation, where it is my job and mission in life to make sure that if your kid has an ear infection in Kissimmee, Florida, that you can get the data for them there. If you bring those two pieces together, right, you could have someone who has gone to another state in which the procedure is legal, gets a legal procedure, and then goes back to her or their state where it is illegal. And the next time that individual goes to a clinician, the clinician, very reasonably looks up in their electronic health record, which are connected to many HIEs and are in and of themselves HIEs. Like Epic is connected to all over the country. And your clinician could see, oh, Nichole got a procedure that was illegal in our state in another state. And so this is something that's causing people, very understandably, a lot of concern, right? And there are some states that even have affirmative reporting laws. It's not what they're called, but I can't remember what it is right now, where, if you see as a provider something that would lead you to believe that someone has committed a crime, that you have to report it. Mandatory reporting. There we go. So folks understandably are very upset, right? Like, you go to another state where it is illegal, you go back to your state, somebody sees the data, what are the consequences there? And so folks started asking that to the Department of Health and Human Services, like, what are you going to do about this? Because it is scary. And not only is it scary, it's confusing. Like, people don't know what to do. Let's at least make the rules of the road so that people understand what to do. So HHS took a year, which is actually very fast, and thought about, okay, how do we deal with these competing interests of wanting to make sure the data gets there, right? Because let's say the same thing, right? I go to a state that has illegal reproductive procedures. I get a legal productive procedure there. I go home and I start bleeding, right? And in my state, it's illegal, excuse me. And so if we just block data from an illegal state, from a legal state to an illegal state, if I show up then at my hospital, and maybe at this point, and this is a dire circumstance, so these are things we have to think about, right? Maybe at this point, like I passed out, like I can't tell people where I just was, or I don't want to tell any of that sort of things. There could be really serious health consequences if the clinicians don't know that I've just had that procedure or I've just had that type of medication. So HHS needed to balance that, right? Needed to balance this idea that we do need health information at the point of care, no matter where that person is. And it can be, and often is, a life and death situation. And we need to make sure that when people go out of state to get procedures that are legal in the state that they go to, they are not then penalized and criminalized in a state where it is considered illegal. So those are the competing interests. And what HHS is proposing, and again, this is a proposed rule, and the comment period has closed. So sorry if people wanted to comment on it, you can't right now. But what HHS has proposed to do is, rather than saying we're just not going to exchange reproductive data, right? Like, that was one option. And again, we come back to that situation of what happens if I show up in an emergency room. Instead of doing that, they said, if somebody asks for these data that is for reasons other than treatment, payment, and operations, so you're asking for the data and it's not for a typical healthcare reason, you're subpoenaing the data or something like that, then that person that's subpoenaing the data would have to provide an attestation that says, I am not going to use this data to prosecute this individual or any other individual in that state. So it tries to sort of balance that by saying we still need the data to flow for treatment, payment, and operations. But if it gets to a point where someone's asking for this data to prosecute for, or even investigate, it includes just investigations or something that might lead to an investigation, and they can't do that. And the way that they're going to enforce that is through an attestation by the individual.
That is something I didn't actually understand. So, I mean, the part that I am scared, honestly, about is just like, okay, the idea that our data could be in some instances used against us. And that part is, and you're like, okay, so it's a privacy rule. We want to make sure that people have a right to their privacy. But,
Mhm.
and also that the appropriate people who need the data to treat,
Exactly.
a person
Yeah.
have what they need. But
Mhm.
ultimately it's a trust factor. And
Mhm.
I think in this specific issue, like we have some work to do
We
on
do. Yep.
building trust,
Yeah.
rebuilding trust.
And I think I know we're close to time, so I'll just like leave this as a teaser. But I think we have a lot of work to do in general, not only about building trust, but honoring patient choice, right? So
Yeah.
in most places right now, the patient choice is all or nothing, right? I can't say I can ask my clinician like, please don't share this information, and they have to take a note of it, and they might be able to do that. ONC is recently released some proposed regulations that would ask EHR companies to have the functionality to be able to parse out that data when patients do that, but we're not there yet. We're not even close to there yet. So um, I'm really lucky to be a part of an organization that feels very passionately about this issue. And so in Maryland, we are through the state, we have what's called a consent management utility. Um, and it has not been stood up yet, but we are working on standing it up. And the idea is that the patient can go to one place and opt in and opt out. That's the first stage. And then stages down the line would be I can opt out of sharing my reproductive data unless it's an emergency, or I can opt out of sharing my mental health, or whatever it might be for you. So that is actually, I think, what the work that we need to do is not so much restricting data more or letting it flow more. It's giving the patient the choice about what is important to them.
Nichole, I know like this, I'm so glad we get to see each other and spend, like, I'm looking forward to meeting you and learning more from you, but thank you for sharing your
Of course.
expertise. And I'm sure that there is so much more that we could learn, but we've only got about a half an hour. So thank you. If people want to connect with you or follow you or engage with you, where would you recommend that they do so?
I'm on LinkedIn. I should probably know. I'm Nichole Sweeney. I have an H in my name. I should probably have like an Instagram or something, but I don't.
It's okay.
But it's Nichole
You're
Sweeney
busy
with an
reading
H.
the rules.
Yes, in printed out form. If you print it out
Yeah.
Instagram form, yeah, I would follow it. But anyway, yeah, I'm in. Feel free to reach out in LinkedIn, and then if it seems like we need to reach out further, I'm happy to provide my contact information.
Fantastic. Thank you so much. I really appreciate your time and all
Of
that you
course.
do.